today's webinar. Before we begin our presentation on the 2012 legislative session, I would like to go over a couple of technical issues. First, you are connected as attendees in muted mode. If you have questions, you can submit them through the questions portion of the control panel. If you will type them in, we will be monitoring them and posing them to the presenters. Secondly, you can connect to the webinar via both audio, via microphone on your computer or And with that, I will turn it over to WSPHA President Nathan Weed.
Well, good afternoon, everyone, and welcome to the March 28th WSPHA webinar, where we're going to be recapping the 2012 legislative session. Originally, we scheduled this webinar with the hope that the legislature would have wrapped up the budget session at this point, but as we all know, special session is still ongoing as our lawmakers continue to work towards an agreement on the budget. You'll hear a little bit more about the budget in a moment from some of our speakers who've been very close to the action in Olympia, but for now, let me say that we've had some very big lifts on budget this session, and the voices of our many partners were critical in doing so. I'd like to thank our partners in the Public Health Roundtable at WSALPHO and in the individual organizations represented in this call today. So without further ado, I'd like to introduce today's speakers. We have Brad Banks from the Washington State Association of Local Public Health Officials, or WSALPHO, possibly the longest acronym ever. We have Vic Coleman from the Childhood Obesity Prevention Coalition, Lucy Culp from the American Heart Association, Aaron, and I'm going to try not to mess up your last name, Aaron Jezig from the American Cancer Society, Jennifer Mumm from WSPHA, Brian Payton from the Department of Health, and Misha Wershko from SEIU Healthcare 775 Northwest. So with that, I would like to thank everybody for all the work they've done in putting this together and all the work they've done in Olympia this session for really advocating for public health. And I'm going to turn this over to Jennifer Mumm to get us started on the budget portion of our webinar.
Thanks, Nathan. So like Nathan said, we had hoped to be able to provide people with some definitive update of what the final budget looked like, and cannot do that, but we can really quickly review where we've been and where things stand right now. So as everybody remembers, last fall there was about a $2 billion budget hole that the legislature was going to have to deal with. The governor put out her budget in November, the week of Thanksgiving, that contained a lot of cuts and also some revenue options that she was suggesting, including a half-penny sales tax increase. The legislature then went into special session right after the Thanksgiving holiday, and during the month of December, they made about $5 million in cuts, which left them with about a $1.5 billion hole to fill during the regular session. And then in February, there was a bit of relatively good news with the caseload forecast that showed that Medicaid use and other state program use was down, which freed up some additional money. And then the revenue forecast for the first time came back, and it looked okay. It was neutral, as the House Budget Chair, Representative Hunter, said. That neutral is the new up these days. So that gave a little bit of a reprieve of just under $500 million. So following the February forecast, the legislature was left to deal with about $1 billion hole. We then saw the House Democrats put out a budget I won't go through the details of that because Brian and Brad and I will do that a little bit in a minute. They put out a budget that was not great for public health, and we worked and had some changes made before they voted out a final budget. The Senate Democrats came out with a budget, which was the first budget hearing in a long time that was very positive because they preserved most services in every category. But then we had an unexpected turn of events just before the session was scheduled to end, with the Senate Republicans putting out a coalition budget. So there were 3 Senate Democrats that worked with the Senate Republicans to put out a different budget. Really an unprecedented thing in Olympia. This had not happened for a long time and was a big surprise and sort of put us into the turmoil of not having a budget deal by the end of the regular session, so the governor immediately calling the legislature back into special session on March 12th, and by law she will call them for 30 days. So we're looking at special session ending around April 10th, and waiting to see whether or not they will come to an agreement on the budget within that time period. So with that overview, I'll turn it over to Brad Banks, who's going to talk a little bit about what has happened with public health funding.
Well, thanks, Jennifer. And as we prepared to go into the regular session, we did a lot of outreach. We, not just WSALPHO, but the public health community, which I think is represented here or represented through WSPHA, and the roundtable. And we tried to figure out some messaging that we could use that would be consistent throughout the session, and try to really have something that we can kind of hammer home across our different areas, which are all slightly unique as they all deal with public health or public health related things in different ways or in different sectors. And so one of those that we sort of landed on, I think, was this notion of public health as a shared responsibility. And what we mean by that is there's a state responsibility clearly, but there's also local responsibility. And I think part of the underlying argument there, I think, and this is just maybe more from WSALPHO perspective, was that this local responsibility needs to not just be a county responsibility, but that cities and other stakeholders need to be, and in the private sectors and others, down to the individual, quite frankly. The individual citizen has a stake in how public health works, and to a more precise degree maybe gets funded. And so this is sort of how we entered session, and I think we entered it optimistic based on what had come out of the budget that the governor the supplemental budget the governor had produced in December. We were not surprised, but I'll go through these bullet points here real quick. I mean, local public health departments, governmental public health, already many of them cut beyond the core. I mean, they're operating at 50 to 60 to 70%, with 60 to 70% less staffing than they had in previous years. Some of them down to just a handful, doing only the most basic public health functions in their communities. And I think what was interesting is that that we just couldn't. It just wasn't. I mean, we were already starting to see a breakdown across the state of some of our communicable disease and other this sort of public health safety network that exists out there. And I think we were starting to already see, and I think have seen actually in this new year with issues like pertussis and other things, how this funding crisis has started to break and erode the system down. Is there a preference here?
You can go ahead with that.
Okay, so I think as we moved forward, the House Democrats put out their budget, and it was not good for local public health funding. Basically what it did, as many of you are well aware, is it swept all of the core shared revenues that go to public health, and those are the Blue Ribbon Commission, sometimes called 5930 money, which was a $20 million investment made several years ago. The MVET backfill money, which was about a decade old, is a decade-old funding source that represents kind of hope to represent sort of 90% of what the cities had traditionally contributed to public health, as well as local community development fund grants, which represent. So we're looking at a total of about $36 to $40 million a year, depending on how you run the numbers and shape them. But you know, about an $80 million biennial amount of money. So it's no small chunk. But at any rate, the House proposed budget swept all those and tried to replace it with about $14 million a year in liquor excise tax that currently gets distributed to cities and counties. Now, what that essentially did, however, and why we had to be so visceral to that, was basically it got the state out of the business of any responsibility for public health. I mean, even the money they had sort of thrown on the table was really redirected local monies. And so the state, for all intents and purposes, or at least would have been out of the business. This was clearly untenable to us, not just us, but us as in everyone on the phone here. So we got together, I think, in what I think was a remarkably consistent and collaborative way. Everybody, the folks on the phone here, others, we had a huddle in my office down here in Olympia, and approached the hearing. I think one of the things I think when public health appeared at the hearing, and whether it was Mary Selecki or us or Labor or Heart and Lung or whoever, it was amazing to me to see how many people mentioned public health across the spectrum as the hearing went on. I mean, I would argue we might have been the single most widely mentioned issue as things went on. And so clearly the pressure amped up really, really quickly from our end on the House Democrats. We were able to work with them and get ourselves brought back to where we were and where we were hoping to maintain in committee, and then managed to, as that passed out of the floor, we managed to be where we had hoped to be. And in the meantime, the Senate budget had come out and held us whole as well, and so we had no real. We felt like we were in a good place at that time. I think we had covered our bases. We had a major hurdle to overcome in the House, which we did through a very collaborative effort, and I thank all those on the phone who helped with that, because it really was truly collaborative. And then as we know, we got this curveball from the Senate Republicans. And actually, to be honest, I mean, there was a $5 million cut in their proposal on that evening to 5930 Blue Ribbon Commission dollars. And this, I mean, I say this now. I mean, it could have been worse, I suppose. But we at the time said, geez, we spent all this time during session working on this, and then sort of at the last minute, there's this late end cut. And that cut is maintained in the version that they have passed off the floor, that they passed off prior to the special session ending. With that said, they have come back out in a media proposal on a budget that hasn't been passed, but on a sort of a new proposal, a supplemental proposal to their original striking budget that puts that money back. And so I think our messaging since then probably has us being held whole as well. I mean, my hope is, and I think others, maybe Brian or others can feel free to chime in on this, but I'm thinking at this point we've probably made our case and done a nice job, and that core public health funding as it relates to local governments will be at least maintained in this next biennial budget. So that's sort of where we are at this point, purely budget related. I don't know if there are any any others that want to comment on that. But again, I just want to say thank you to everyone on my association's behalf, to all of the partners who helped us carry that message and really show not only how public health is a shared responsibility, but how it's a collaborative process, and it affects everybody in varying ways throughout their daily lives. And I think that was a really important message. And I think public health this year, not just from our, not just governmental public health, but public health proper, was really brought up in a number of public ways this year on the Hill. And I think that was really, it really speaks to the good work that all of us are doing, I think, to really elevate the discussion about why it's so important and what it really does for the communities that we live in. So that's really kind of where we are with public health funding. I don't know, Jennifer, was there anything else beyond that that you would like me to touch on?
Thank you, Brad. I think that was great.
Okay.
We'll move on to Brian Payton discussing some of the reductions within the Department of Health budget.
Thank you, Jennifer. I wanted to start out just by sort of talking a little bit about where we came from in all of this. The governor's budget in November, December, that was developed and released, cut $14.5 million in general fund state from the department's budget. And we talked about that in an earlier webinar. There were some fairly healthy cuts or hefty cuts in HIV/AIDS, some of our maternal and child health programs, some small cuts in family planning, and a number of other functions, environmental health, some of the things we're going to talk about here. As Jennifer mentioned, when the legislature convened in its special session before the regular session, they did pass what was referred to as an early action budget. And at that time, they cut about $900 million from the department's budget, mostly administrative costs, some data collection costs. So just wanted to give you a sense of our context here. You can see that between the 11-13 biennial budget that was adopted and then the so-called early action budget, it doesn't really change the department's funding composition. We remain half federal. That funding has actually increased a little bit every year. General fund state is only 15% of our budget at this point. We have some dedicated funds from WIC rebates, from the Model Toxic Control Act and others, and then fees. So that's kind of where we are. Nothing so far has changed that. Next slide, please. So I want to talk about some of the larger areas of cuts and where they appear in these budget proposals we've talked about. There's a $410,000 reduction in our emergency medical services trauma councils and in the area health education centers rural health contracts. That's support we provide to local entities to work on rural health and EMS trauma. That is in both the Senate and the House budgets as they have passed. So that's probably going to happen. Next slide, please. There's a number of items, environmental health risk protection having to do with lab testing and, for example, some of our zoonotics, animal-borne disease programs. $1.2 million reduction. That is in both the Senate and House budgets, and so it's likely to stay in. Next slide, please. Oh wait, no. So that's not my slide. Let me touch on a couple different other things. Family planning grants. There was no reduction in the House budget. There was a $6 million reduction for family planning grants in the Senate budget that was adopted. That was a little controversial, and as you may know, that the Senate proposal, a new Senate proposal was released about a week ago, 10 days ago, and they restore half of that cut. So they cut only $3 million in family planning in that budget. The future of that budget is uncertain, as you know. It hasn't been voted on or had a hearing, and so I guess we're all just waiting to see when there will be some agreement. Brad did comment that it looks like public health funding is pretty well cemented in the budgets because of the advocacy that you all have done and showing up in all of them, and I would say that's correct. The new Senate budget that Senator Zerelli released restores the small public health cuts that were in there, so I think we're pretty well set.
Thank you, Brian. So just to touch on some safety net programs briefly, the Washington State Public Health Association put out its 2012 legislative agenda, and among the budget concerns listed a number of safety net programs that were up for either significant reduction or elimination in the governor's budget proposal in late 2011. I just want to touch on those really quickly. There's some good news in this slide in that many of these programs have taken no further reduction in any of the legislative proposals. So to start with, that's certainly the case. Maternity support services has seen no reduction, no further reduction in any legislative budget proposal. Family planning, Brian just touched on that. No further reduction except what is now a $3 million reduction in the Senate Republican Coalition latest budget proposal as of March 15th, which, as Brian said, has not been voted on. That's one where I think there's some hope that that might be changed or experience no cut in a final negotiated budget. The basic health plan has had no further reductions in any budget proposal. Disability Lifeline medical has been eliminated in the Senate Republican Coalition budget, both the earlier version that was passed and the latest budget as of March 15th. So I think that there's some work going on around that still. Apple Health for Kids has had no further reduction, although the latest version of the House Democrats budget did provide some additional funding, about $500 million additional funding for outreach activities, and that would be matched with $500,000 from the feds, so about $1 million add. We know that getting more kids enrolled is not only the right thing to do, but it increases the CHIPRA bonus that comes into the state at the end of the year. So there's also some hope for that money to be included in the final proposal. Medicaid pharmacy, which for those of you who are at the Joint Conference on Health or were on the earlier legislative webinar this fall, that was a big concern for many people. And while there's some formulary change that's been proposed in both the House and Senate budgets, there's no major reduction there. Medicaid interpreter services was another concern that's seen no reduction. And then mental health and chemical dependency services, depending on which budget you look at, there are some reductions there that seem to be agreed upon things that will likely move forward because they're the same in both the House Democrats proposal as well as the latest Senate Republican proposal. So there's some funding for residential services and treatment for chronically chemical dependent or disabled people. That has been eliminated in both the House Democrat and Senate Republican budgets. The House does shift some of that funding to outpatient services. And then there's an additional reduction that's included in the House budget to actually close 2 wards at Western State for patients with traumatic brain injuries or dementia, and instead to place those patients in long-term care settings within the community. So we've been monitoring those as well. The other piece of chemical dependency services that has been linked with Disability Lifeline, at least in the Senate Republican proposal, is the Alcoholism and Drug Abuse Treatment Support Act, which is known as the ADATSA program. So with that wraps up our budget portion of the webinar. So we can take some questions if there are any at this PowerPoint on budget. Betsy, did you have any questions?
Yes, we had one question come in. I was just waiting to see if any more were coming in. Regarding asking Brian to elaborate a little more on the environmental health cuts and what the exact programs that would be affected.
Yeah, there are, I'll try to give you a high level. There is some changes in data collection activities for our drinking water program, how often we input data, how much data we input. There is a reduction in some of the technical support that we can provide to public water systems out in the field, a reduction in technical assistance. There is a reduction in some of our compliance and technical assistance and assessment activities with regard to on-site sewage and some of the Puget Sound initiatives involving those Puget Sound counties. Another small reduction for our on-site sewage design and review and approval team, and then some reductions in water testing and support positions at the State Health Lab. So it's an assortment of various things that adds up to that $1.2 million that I mentioned.
Thank you. We also had another question come in. Can you be more specific and elaborate on the ADA TSA cuts?
I'm going to ask if any of our other presenters know more about that particular cut than I do.
Can you repeat the question, Jen?
Yeah, if we have any more information on the ADOTSA cut. It's the alcohol treatment program that's been combined with Disability Lifeline Medical in the Senate Republicans' budget.
I don't, but Brad, if you're still on the phone, if someone submits that question in writing, perhaps Rashi could help answer that. I think she tracks that, or Carrie Morris. If someone has a specific question, I think we can help run down the answer.
Yes.
Well, so Rashi is actually in my office. If you'd like her to answer, I think she'd be more than happy.
I didn't mean to call her out.
No, I she just whispered to me, I think I can answer that.
Yay! I was thinking Rashi could. Great.
So the ADOTSA piece, so when you look at Disability Lifeline, the latest Senate version of the budget, as you're calling it, eliminates all of Disability Lifeline. And there's three pieces. There's medical, there's a chemical dependency piece, and there's the housing piece, which we're calling the housing and essential needs. And so as part of the reduction, they actually eliminate all three. And ADOTSA is a piece of the Disability Lifeline chemical dependency funding. And what the ADOTSA funding mainly funds is single men without children, because there's always other funding specifically for parenting and pregnant women and things like that. So it's that piece.
If you want to follow up while I'm talking, but overall there's been no reduction in state funds to the breast and cervical health program in any of the proposals at all this year. So I don't know if there was a specific question to that.
No, I think that should answer it. Thank you.
Okay, thanks.
And that is it for questions on the budget portion.
Thank you, Betsy. So I think we can move then into the policy bill section of the webinar. Here we go. So Brad, do you want to get started on a couple of the environmental health bills?
Sure. So the first bill that I'll mention is 5234, Senate Bill 5234, which is Secure Medicine Return. And I know many of you could speak to this as well, as you've been involved with this probably longer than I have. But the bottom line is this bill did not pass, although being a priority, as you can see, not just for WSPHA, but for other entities, and actually including the Association of Counties, has supported this and has had this as part of their agenda for some time. Basically, what this bill would have done is establish a medicine return corporation, kind of a nonprofit entity that would serve as the return mechanism and stewardship mechanism for medicine return at a statewide level, basically. And this in many ways would be a first in the United States. Washington always liking to be the first out there. This bill is very, very controversial because mainly maybe that's not an accurate statement. It's controversial to certain people and entities, mainly the pharmaceutical industry, because this bill would ask them to be the funding source for this statewide system. And the cost from our perspective, $2.5 million a year for an industry that makes billions upon billions of dollars a year seems like a relatively small drop in the bucket, and we thought very reasonable. And we also think that there was some element to, or some argument to be made that they're the ones producing these medications, and so they should have some stake in the impact that they may be having on the environment and on folks' health. And so while we, and there are others that did huge amounts of work on this, Margaret Shield and others, we were optimistic again that coming back this year we may be able to wrangle the 25 votes we needed in the Senate to get it out and get it over to the House, and be in good shape. When there was, just as there were starting to be rumors that this bill was going to make it to the floor and get pulled by leadership, the pharmaceutical industry in full force came out, and I mean it was actually quite the scene outside the doors in the Capitol in Olympia, the number of lobbyists that they had on hand for this, and managed to strip away enough senators at the last moment to basically keep this from being pulled up to a vote. And there were continuing rumors that maybe at some point a similar tack to what they took with the coalition budget going to the Ninth Order, something like that may occur on this bill. Nothing ever really materialized, and it again sort of died in the water. And so we're left again with kind of the same, I think, feeling that we've had for the past couple years, I think going back maybe 4 years or more on trying to do this. And it's unfortunate because many local health jurisdictions and counties in general have their own systems in place and are doing some really, really great work. It's just unfortunate because as budgets continue to shrink, this is just not something they're going to be able to sustain. I mean, it's really existing in those counties that still have some ability to have these type of programs in place, but I think we're going to see less and less of that as they're having to just constantly prioritize really on what are the core activities that they need to be performing. And so, it was disappointing. I don't know that it was entirely unexpected, but it's something I think we in the interim need to have a discussion about. Do we want to try to come back the same way next year and try to do this again, or do we want to try to change our approach maybe a little bit and go at it from a different angle? I don't know. That's just purely hypothetical from my standpoint. But I also think this being an election year was not helpful. You know, this adds a lot of pressure on. Although I have to say there were a handful of conservatives and Republicans that, you know, including Senator Swecker, who last year there were some issues, but this year he stood firm from what we could hear he was going to do. So I don't know. I mean, I think we'll see where this goes. At this point, it is what it is, and we'll try at it again, because I think fundamentally it's the right approach. I think it's the right answer. I think it provides a great solution, and I think it's a very cost-effective way to really make a large impact on the environmental health of our communities. So, but we'll see.
Thanks, Brad. We'll let you switch gears here for a minute.
Okay. Yes. So Senate Bill 6116, which dealt with on-site sewer program management plans. It's an interesting little bill, sponsored by Senator Frazier, and I'm kind of coming out of Thurston County, to be honest. It was interesting because this bill was maybe 5 lines, 6 lines, something like that. I mean, it was a tiny paragraph, and basically what this bill initially did was, and it did have statewide application, it allowed local boards of health and local health jurisdictions to use the property tax statement as the collection mechanism by contracting with the county treasurer to be the collection mechanism for fees and charges on on-site sewer program management plans, which the 12 Puget Sound counties by statute are obligated to have these programs in place. I think the initial attempt, this bill had been introduced last year actually, but for some technical reasons got kind of fouled up and didn't make it out. And so this year there was a lot of work done on the interim by Art Starry and others to really get the cross the T's and dot the I's to make sure we're coming back to something that was very specific. Well, what interestingly happened, what we thought was, I think, a very simple bill and should have been probably relatively simple, although from what I'm hearing, that's, you know, like never really is the case. But this little bill managed to, it did get out of committee in the Senate, and that was sort of its first movement. The issue, though, that was raised was, we don't want local boards of health or local health jurisdictions to have the ability to foreclose on property or have lien authority on property based solely on somebody not paying their sewer bill. You know, so for $85, they didn't want the county or the local health jurisdiction to be able to foreclose on somebody's house. We were okay with that. Quite frankly, I don't know what we would do with the house if we foreclosed on it anyways from a local health jurisdiction perspective. So we didn't have any concern with that. That language was added, just a line specifying that we didn't have that ability. It got out of committee and then passed out of the Senate unanimously. Well, in the meantime, the treasurers got very upset with this. They felt that it eroded their ability to ultimately collect on delinquent fees. I think our argument was consistent to say, by and large, by using, should a county choose to, and this, let me back up a little bit. I think what's important to remember about this bill, even from the beginning, is it's completely permissive. Nothing in the bill requires a board of health to do anything. It just is really a tool in the toolbox for them to use. So basically, what the bill finally, as it meandered through the House, it had some initial, some other changes in committee. The treasurers were a little upset, so there was some added language in there, although lien authority was never actually added back in. And there was some additional, some concern from some of the east side counties and local health jurisdictions that viewed this as a potential for a new fee. So that started swirling around, and so the bill got really contracted back to just those 12 Puget Sound counties, and then managed to get out of the House, and then those changes were concurred on in the Senate. So the bill is passed. It's a good little bill. I wish it had remained statewide, to be able to be a tool for all jurisdictions to use should they choose to. But it was contracted back to just the 12. So at least for now, those 12 will have an additional tool should they choose to use it. And I think in an instance in like Thurston County, this you're talking about a program. I don't have the numbers exactly, probably accurate here. A program that generates $150,000 in fees, but costs $40,000 to $60,000 to administer. And so it's really an issue of efficiency and streamlining the way we do business and cost-effective work. And so this will provide them a way to have something that's standard, state, county-wide, that can be collected at a, anything that's put on a property tax statement gets collected at a high level. And so just the number of delinquencies probably would go down as a result, as well as just having, more money freed up as a result of a cheaper collection process that can go back into education and community outreach on these issues. So it was a good bill. I appreciated those that helped on it. Like I said, didn't get out in exactly the form we would have been totally pleased with, but it got out in a way that's still very useful for at least some counties. So that's that. I don't know if any folks had any questions on that bill in particular.
We don't have any questions on this bill, but we did have a question on the secure medicine return, which was you indicated that the costs are limited to $2.5 million per year, but would they actually reach that level?
I think the reason, and there may be somebody else who can answer that better, but I think the reason they that number was chosen was because that would be well within the means of funding this statewide program.
Thank you, Brad. So next we're going to shift gears away from environmental health into another major issue of this session, which was a bill that essentially does implementation of the Affordable Care Act. So Erin Jajic from the Cancer Society and Nisha Werschel from SEIU 775 will talk through this bill.
Great. So this is Nisha. Hopefully you can hear me. I'm going to start us off and then hand it over to Erin. So both SEIU 775 and the Cancer Society are members of the Healthy Washington Coalition, and also the Washington State Public Health Association is also a member. It's a coalition, a large healthcare reform-focused coalition made up of community organizations, labor unions, faith-based groups, provider associations. And this coalition really worked together this year, trying to pass legislation, which we successfully did pass, to really create the framework for our state health insurance exchange. So a couple things just by context before we get into the specifics of the bill that passed this year is that really this is actually the second bill that's passed, sort of creating the framework for our state health insurance exchange, or our new marketplace for people to buy health insurance. Last year, many of you probably remember that legislature passed Senate Bill 5445, which started us down the path of creating a state exchange. It determined that the exchange that we set up would be a public-private partnership and kind of set up the process for the governor to make appointments to sit on the board. There's 8 members of the board and 1 chair of the board. So, so the legislation that passed this year really was kind of building on the legislation from last year and kind of taking us one step forward towards implementing healthcare reform in our state. And the state exchange really becomes effective January 1st, 2014, and really is the marketplace where people will be able to buy insurance in the individual and small group market. One statistic that I read that I just wanted to share is that, approximately half of the people who are currently uninsured who will receive health care, be able to purchase health care with the Affordable Care Act, will be purchasing it through the exchange. So it's a pretty significant change to our healthcare market. It's a pretty significant piece of legislation. So I think what we wanted to do is just walk through a little bit what the bill this year did. Try not to get too into the technical details. It is a very technical bill, but kind of share that information with you and then answer any questions that you have. So the first piece of the legislation that we wanted to touch on is the exchange board and staff. And if you're following along in the PowerPoint, you'll see this, but really as I mentioned, the legislation last year, 5445, sort of established the process for appointments to the board, but really didn't give the board sufficient authority to really build what needs to be built in our state. And so the legislation this year expanded the authority for the board and also allowed the board to hire employees. The board, like I said, is made up of 8 members and then 1 non-voting chairperson. And, they meet to make the, to guide the direction of the exchange, but need to have staff to actually implement. So that's a pretty significant change in and of itself to actually be able for the board to have this authority and to hire staff. The second piece that I wanted to talk about is exchange financing. So the goal of the health insurance exchange is for it to be self-sustaining. So essentially, no state funds would be used to cover the costs of the exchange as of 2014. And so there is a variety of different ways the exchange could basically cover the costs. Right now, the exchange is being paid for, the development of the exchange is being paid for through pretty significant federal grants that we've received. There's a level 1 grant and soon to be, I think, a level 2 grant for the development of the exchange. But the bill that passed this year and was just signed by the governor last Friday basically sets up a process to try to determine how the exchange will be financed. And some of the options are federal grants, fees that would be charged to carriers, the subsidies that would be received through the exchange. So there's a variety of different ways. And the bill sets up a process to get input from health carriers to try to determine what the right way to finance the exchange will be. So that issue will be going back to the legislature next session for them to make a recommendation on, or if they do not make a recommendation, then the recommendation coming out of the board will be implemented. So that's another piece, kind of technical piece, but important for the exchange to be able to move forward. It needs to be, find a way to be self-sustaining. The third piece, which is really a really big issue, is the affordability and the federal basic health option. I know many of you have probably been tracking this issue. There is a concern that the subsidies that will be available through for individuals through the exchange may not be sufficient to make the healthcare options really affordable for participants. So there's been a lot of work in our state looking at how do we build on the success of the basic health plan that we have today, how do we make sure that we have an affordable option through the exchange, and trying to really see if there's an opportunity to take advantage of a provision of the Affordable Care Act that was really put in there by our Senator Maria Cantwell to create this basic health option for the state. So what the legislation does on the basic health option is it's a little bit complicated, but basically it allows us to, as a state, move forward on developing a basic health option and doing preliminary planning for the basic health option, but really leaves the decision back to the legislature in 2013 if we want to move forward on this. So you'll hear that a number of the different areas I've talked about, there is pieces, decisions that were made, decisions to move forward, but there's a number of things that have been pushed back to the legislature for 2013. So this will continue to be evolving. But if there is an appropriation in the budget when it's passed to develop the federal basic health option, do preliminary planning, the Healthcare Authority will move forward on that this year to allow us to move forward. So folks can ask questions about that piece at the end if you have any, but basically we're starting to move forward, but again, going back to the legislature for a final decision. And then the final piece that I'm going to talk about just before turning it over to Erin is the qualified health plans discussion. And again, this is sort of technical, but basically the issue is that the state exchange will essentially qualify plans as qualified health plans in our state that will be available for people to purchase through the exchange. So one decision for this year is sort of what are the requirements for a qualified health plan. And what the decision that the legislature made on this issue is to basically require the federal minimum standards and not add a lot of specific state requirements at this point. There is one addition that was added to allow, to ensure that tribal clinics and urban Indian clinics are considered as part of the plans for most of the insurers that will be offering plans through the exchange. But other than that one provision, there really was a decision by the legislature to kind of set up the exchange from the beginning as simply as possible and not add on a number of different additional state requirements right from the beginning. But the really positive thing about the qualified health plans is that there will be a mechanism for consumers to compare coverage and really become engaged in making good choices about their own health plan. And so there'll be a rating system that's available for individuals to compare plans on a certain set of criteria. So the last thing on the qualified health plan before I turn it over to Erin is that there's a standalone dental option that will be available through the exchange. And the legislation that passed this year kind of sets up that opportunity to have that option in our state. So, so those are kind of four of the main components of the bill, and I'll turn it over to Erin. Folks can ask questions.
Exchange and an external market. And as some of you have seen me do this visually, I put my right hand, that's like inside the exchange, the left hand is outside the exchange. Visualize a line down the center. And not everything's going to have that firm line, but it really does begin to have two marketplaces in our state, whereas right now we really just have one for an individual or a small group seeking insurance. And so one thing the bill did, and we were the first in the country to do this, is we picked a benchmark plan for our essential health benefits. Some of you will remember when the Affordable Care Act passed, there was going to be this set of standards on 10 areas that every plan would have. And the goal was to have it a nationwide standard so that every country or every plan sold across the country would have these 10 categories covered in the same way. And in December, HHS punted that decision back to the state. For a state like Washington, that may actually be for the best. We have a lot of mandates and patient protections that we now get the option to keep, whereas if we move to a national standard, odds are we may have taken a couple hits to come down to the norm. So our state in this bill did pick the largest small group market plan as our essential health benefit. So what that means is that the coverage in the 10 categories for the essential health benefits will be what's in that plan that's the most popular in the small group market. I'll tell you why this is pretty good for those of us that follow public health issues. It means all of our mandates will be covered. And bottom line, this was the easiest political pick, and it has the best patient protections. So I'll say this was a solid decision. It doesn't come without concerns, and there are obviously holes there, but out of all the plans to be assessed, this was probably the best fit for our state, especially for those of us concerned with prevention. That goes into effect in 2014 in the internal, so in the exchange and outside the exchange, plans sold. And it gives the OIC some authority, sorry, Office of Insurance Commissioner, Mike Kreidler. You know, he's the one overseeing this and regulating it, and he does have authority there to look at if there's a way the plans are being created to see if they're doing adverse selection. And that's something that was really important to a lot of the disease groups, for lack of a better term. We cannot think of a better name. But, you know, cancer, Heart Association, Lung Association, MS, was we have this great system that's going to be set up. But now that they can't exclude people with pre-existing conditions or some other behaviors the insurance carriers have been doing, what is going to be the next thing they do to try to shift costs to sick people or avoid paying for the really expensive? So in this section, Kreidler gets some authority to look to see if they're crafting plans to do adverse selection. Again, if that's hurting the sick people, the easiest way to think about that. And moving into the next one on the insurance market rules, this is an area that we worked greatly as consumer advocates on, and we had some big wins here. What we're talking about here is that, again, look at your right hand and your left hand, inside and outside the market. We need them to act in tandem and together so that that exchange where people can have a subsidy, so someone that doesn't have insurance right now gets a subsidy and comes in, we all know there are really strong correlations between poor health status and low socioeconomic status. So we became very worried that the exchange could become a de facto high-risk pool with a bunch of sick people coming in, or people with chronic disease that haven't been managed, or other conditions that would make that pool go into a death spiral, because it would be all really sick people. And all the healthy people would continue to buy outside the exchange because they don't need the subsidy. Again, the correlation between socioeconomic status and health. So we did 3 things here that are really important. If you talk about inside and outside the exchange, visualize the 2 sides. The catastrophic plans, you know, those lowest level coverage plans for young adults can only be offered inside the exchange. That was a big deal because we didn't want these low-level catastrophic plans offered outside the market and drawing the good risk out there. Insurers that come into the state and they're just going to play outside the exchange, they have to come in and offer 3 levels. They just can't come in and offer bronze. They can't come in and offer that low-level plan. Like if Aetna or somebody's going to play in our state, they need to offer bronze, silver, and gold. And so that allows for a lot of selection outside the exchange. And the last one I just want to bring up that gets to adverse selection is that we gave the OIC, again, Mike Kreidler, some rulemaking authority that really starts to look at prescription drug benefit design as a means to adverse selection. And we're already starting to see this with the advent of specialty tiers, where medicine for chronic illness or crisis diagnosis like cancer or MS suddenly has a 50% co-payment on a $5,000 drug. We're starting to see those more and more, and so we did give the OIC this authority to start looking at prescription drug plan coverage as a means of adverse selection. The next one I'll get into, again, was a critical and is an ongoing issue. I'll say those market rules are now passed, they're signed into law, and they hold until the beginning of 2016, and then they'll be looked at by the legislature and the Office of Insurance Commissioner to see if they're still needed. We wanted strong market rules, like telling how the markets would act with each other as we launch to make the exchange as stable as possible. But if it looks like we don't need them in 2016, they'll be reviewed. And then, so the next section I'll get into is reinsurance and WSALPHO, and I think these go together. And some of you may have heard of or have friends that are on the Washington State High Risk Pool. It's a place right now for people to go buy insurance that gets denied everywhere else. A great example is if you have cancer or you're a cancer survivor and you're seeking insurance on the individual market, you'll often get an insurance quote that's outrageous, and it'll say, we'll cover everything except cancer. So again, pre-existing condition exclusions. The high-risk pool has been a lifesaver for so many people, and in this bill, they just start to talk about the process for evaluating WSALPHO and how it ends. There's a real concern of shutting down the state high-risk pool right as the exchange launches, because you will get a flood of very sick people. The 2 highest diagnoses in WSALPHO are HIV/AIDS and cancer. So think about how much those people cost. We don't want a flood of very sick people hitting the exchange all at once. The goal is to set up so it's a slow matriculation over into the exchange. That's for stability of the market. Groups like Lifelong AIDS Alliance and myself and others are also very concerned at shutting WSALPHO down right now because it has such a robust prescription drug coverage, especially for people with HIV/AIDS, where we don't see the tiering and the exorbitant cost sharing that we're starting to see in the private market. So what happened with WSALPHO in this bill is they set up a process to figure out how it's going to end and how it's going to transition. No decisions are made there yet. And that goes in tandem with something called reinsurance, which is dictated by the Affordable Care Act. I think the easiest way to say it is it's kind of an invisible high-risk pool. It's hidden behind the scenes. It is a way that an insurer, let's say Premera, I'm on Premera and I get cancer. You know, they have a period of time to kind of sell me to a third-party insurance on the back end. It sounds really shady. I'm very clear on this. It sounds shady. It is necessary. The insurers agree it's necessary, and consumer groups agree it's necessary because it shares the risk. And the patient never knows. It's on the back end. It's very tricky, and it's actually tied to WSALPHO. And so what you see in the bill is it sets up a process to analyze and figure out the right reinsurance mechanism for our state. This stuff is super wonky, but actually really matters for those that are sick. And that's where the game is at with insurance. You don't know what you have or don't until you get sick. Allowing Primera to cede my risk over to a third party actually keeps rates down if the system's set up correctly. And I was happy to see a process was set up instead of ramming an idea through, which is what it was looking like for a while with the bill. I think the next piece is navigators. Do you have a slide on that? Yeah. This was actually ended up being a very big fight. The two fights that a lot of us, again, with the chronic disease or disease groups were involved in were those market rules and adverse selection. And then at the end on this navigator issue, the Affordable Care Act clearly wants navigators to be people that can help people find the right insurance for them. In that, you already have Lifelong AIDS Alliance that acts like that with folks with HIV, AIDS in the state called Evergreen Health Plan. NS could become one. Cancer could hire someone that helps people look at the plans and assess it. Our language in the bill was written so that it clearly stated a navigator doesn't just have to mean you're someone that makes money. Because the brokers really wanted to define that an insurance broker would be the navigator. And so this is a tiny thing, but this is actually a big win because it allows community-based groups or disease-based groups to operate as a navigator to help people find insurance. So I think that's everything. I think I went a little over. I apologize. So do we have questions at this point?
We do not have questions at this point, but I imagine there will be some coming in that we can pose to you at the end, if that will work.
Okay, I think Misha has to hop off. I'll stay on the phone, and if questions arise, I should be able to stay on until 1:30.
I can actually stay on too, Erin. Thanks.
Okay. Thank you both. So obviously a very big, complicated bill. We're going to switch gears again from health reform and the health exchange to look at some bills that sort of combine healthy eating, active living, and some transportation policy. So Vic and Lucy, you're up.
Okay, thank you. I'll start. Vic Coleman with the Child Obesity Prevention Coalition. Let me start by talking about House Bill 2370. This was to include an element related to health in the state transportation system policy goals, which are in statute. They've been kind of scrubbing these goals in the last couple of years, and there are some phrases in there that could relate to health. They use the term healthy communities, probably not quite in the way that we talk about it. And this bill, it was the first year for this one, and it actually went very far. It had a very terrific start in the House and even had bipartisan support in the House Transportation Committee. It did revert to a more partisan vote on the floor. And then we did hit a wall in the Senate in front of the Transportation Committee there. So we do have some challenges ahead to get it through that committee. But a couple of points around the bill that were really positive. Representative Billy Spokane was a terrific advocate for this issue, really put a face on prevention of public health in a really plain talky sort of way, and it was a very strong internal advocate. We also, and he's very motivated to reintroduce the bill next session. The other piece that came in is our organization got some special dollars from the National American Heart Association that has this rapid response fund regarding polling. And so we did grab some initial polling data around this particular portion of what's termed active transportation. And the polling data was quite positive. We had really strong support for this idea even before the arguments were presented, and the support grew as folks heard more arguments. And we did have bipartisan support in that poll data. So all to say, I think the world is turning. We're getting away from a more car-centric sort of headset, even with our policymakers. And I do feel like the Senate Transportation Committee is sort of like holding on to that old headset, that old way of looking at transportation. And I feel like we have really only a positive way to go on bills like this in the future. I will say, too, that in addition to the particular Transportation Committee and their chair as a challenge, We also need to message carefully about making sure we don't over-message around health impact assessments. And I'm sure most of you know these HIAs are tools that are used in varying ways across the country, and I think there was a concern aired a little bit, sometimes sort of underground, about whether we will utilize HIAs in all future transportation projects that can be very expensive, and that's not what this bill was about. This bill is simply trying to say, let's grab what data we can to say, if you build a transportation project this way, here's the impact on health. If it goes another way, here's that impact. So it's information. It's not supposed to be a deal maker or breaker on whether or not the project goes forward. So more messaging, more precise messaging will be helpful in the future on that bill. So I'll just move to the next bill and see if there's questions that roll in on either of these. So House Bill 1217, another bill related to, I'd say, that active transportation arena. This was a bill that would provide greater utility to local governments to establish speed limits under 25 miles an hour. Currently, they do have that power, but it's quite a lot of hoops to jump through to get permission to go below 25 miles an hour. And so in neighborhoods that are dense and neighborhoods that have sensitive land uses, where there's children at play, whether those are schools or parks, currently it's very difficult for municipalities to lower those speed limits. This bill would really get rid of the hoops and make it more primary of a process for local government to do that. This bill flew through the House both of these years, and this year had even a more robust hearing in the Senate, and really, frankly, I think ran out of time to get the issues fully aired. Also had a good sponsor on this bill, Cindy Ryu, and she's, again, committed to pushing this idea in the future. And public health was brought into this bill in a much bigger way this session, this year, than in the first year. So, again, we see good things ahead for this idea in the future, and feel like, because it's about local control as well as safety and public health, we can get a lot of messages going at one time with this bill. I'm going to move to 1801 unless questions are popping on either of those first two bills. And I don't know, Lucy, if you had any other comments to add on those bills before we get into procurement.
No, we're good on my end. I'm happy to try to answer questions.
Thank you. All right, so House Bill 1801, this is a bill that, well, let me just back up on the other bills. I got to say our partners were terrific on those transportation bills. Transportation Choices Coalition was really the lead on 2370. We worked very closely with them. And the Bicycle Alliance was the lead for House Bill 1217. And we're just making stronger friends and partners all the time with groups like that. On 1801, the Childhood Obesity Prevention Coalition worked with Lori Jenkins. As some of you may have heard of her, and she's been a terrific advocate on this issue. And we got a little further down the road on establishing food procurement standards for state agencies when they purchase food. Right now there is a food umbrella contract that can be utilized, but agencies can and do go outside that contract to purchase food. So we were very interested in establishing some baseline nutritional standards for state agencies, trying to make the point that we see our governmental entities as models, and we would love to see governmental units adhere to nutritional standards when they put on a hat as a food purchaser, whether it's for their employees or whether it's folks they take care of. So we've worked the policy part of this bill pretty hard, and we did get to, I think, a resolution with the affected state agencies on the policy part of this bill, but that took some doing. We also had the Health Department helping out on this bill. This is a policy priority area in their CTG grant, so we partnered with them in working through the policy part of the bill, but we ran out of time to get a full airing of this bill in the fiscal committee. We did not get a hearing in the Ways and Means Committee. And there is a fiscal note on the bill that had good news and bad news in it that we didn't quite get aired. The good news was Department of Corrections had a zero impact on the bill because they have changed quite a bit in the last couple of years on their nutritional standards, and they were actually good with the standards and didn't think that would impact them. The SHS, however, did feel there would be a pretty big impact on their purchasing of food, and they had some pretty big assumptions about how healthy food costs. I think the number was 25% more was their assumption. So there's more work here to do. I think next steps, the health department is looking at establishing a work group with across state agencies to continue to look at this issue and work with the agencies. And we'll obviously be part of that effort, and we'll assess after that work group is a little more downstream about if and how we push a bill in the future. So let me stop there and see what Lucy might want to add to that whole process. The Heart Association was a very strong partner with us on this bill.
Sorry, Vic, you were actually cutting out for me, so I didn't get to hear everything you said about food procurement. So I don't think I have anything to add, but again, happy to help answer questions on this bill.
Well, I hope I wasn't cutting out for everybody. That would not be good. Okay, just a couple quick sort of tie-up comments. I would say, you know, our coalition has been trying to look at Olympia and the state legislature as a place to get some policy work done on that broad arena of healthy communities. And I think it's a pretty mixed picture looking at whether that's a place to get policy work done. And the comment I would offer is I think there's probably more game, at least in the near term, on active transportation work than there is on the nutrition side. And there's probably lots of reasons for that, but we do have really strong partners in active transportation. They seem to be a little more organized and pulling together a little bit more and maybe a little better funded even than the nutrition side of the street. We need to work all those issues together, but just from a political feasibility standpoint, I would say that you might be seeing more efforts, more focus on the active transportation side. So I think I'll leave it at that and see if there's any lingering questions. Thanks.
Thank you, Vic. Betsy, do you have any questions coming in?
We don't have any questions at the moment, but I'm sure we can answer them at the end, too.
Sure. Okay, so Lucy is going to talk about a favorite topic of cigar bars next.
Okay, yeah. Favorite topic. I don't know whose favorite topic this is. So let me just start by saying, Aaron or anybody else who has helped work on these tobacco bills, please feel free to jump in or add anything. So cigar bars, there's a House Bill 1683 and a Senate Bill 5542. These actually came up in the 2011 session and then came, we're back this year. Jen, do we have more slides, or are those not there? This is okay. If they're there, I wanted to.
Yes. Yeah.
Okay. So these bills create loopholes in Initiative 901, and that was our smoke-free law that passed in 2005 with over 60% of the vote. It passed in every county in the state. So this allows for 100 lounges and 500 stores to allow basically anything but cigarette smoking back in. So we're talking cigars, pipes, hookah primarily. I mean, that's kind of our assumption about what's going to be in these places. And when you talk 600 locations, that's almost as many Starbucks as we have in the state. So it's a lot. I mean, this is a big impact. So in 2011, they actually, towards the end of the session, the funding what little revenue comes in from these bills was tied to tobacco prevention funding, which made it a little more challenging to defeat. And it really went into the final hours of the session before, thankfully, not passing last year. So for the 2012 session, we really wanted to come out strong against these bills. We did some polling and saw that while in 2005, the support for this was around 60%, now it's gone up to 84%, just in support for clean indoor air. And when you go a step further and ask people what they think about, carving out these kinds of exemptions, 71% of people oppose. And that, I think, was really powerful data to have with the legislature right at the beginning of this 2012 session. We did a lot of media, a lot of outreach right at the beginning. Hopefully some of you all saw Erin on In5. Did a great job being a media spokesperson for us. But I want to say this is still alive. This 5542 is actually in the most recent Senate budget proposal. And we would ask that on your personal time, you please take the time to take action on this. We have, I think, the Heart Association, Lung Cancer, Campaign for Tobacco for Kids, all have live action alerts going on this. Visit our site, take action, get letters into your legislators. We've still got to, we've got to make sure they know that people care about this still. We haven't gone away. We still care. 71% of people oppose it, and we've got to keep fighting. So I think that's it on cigars, unless somebody wants to ask a question or wants me to stop there. And I'll jump into 6166. This was actually a $1 increase in the tobacco tax. It brought in conservatively about $40 million, and the bill was written so that $1.7 million would actually go into reinstating quitline for the uninsured. So you all might remember we used to have a state contract with the quitline that covered, well, I mean, lots of people actually, but the uninsured and underinsured were a pretty key piece of that. And in the 2011 legislative session, that was completely eliminated. So that $1.7 million was really just to reinstate that service. So again, we did some polling, and it polls pretty well. Even after an increase in 2010, 64% of people still support a $1 increase. And when you tie that revenue to prevention or cessation services, it goes up to 71%. This bill didn't move this year, I think, for a number of reasons. One being that for any new taxes, there has to be a 2/3 vote, and that's a pretty tall order in this political climate. So that bill did not pass. So I think that covers the tobacco bill.
Lucy, can I add something really quick there? And I just want to say that in all the budget proposals at this point, I believe there is $1.7 million for the quitline restored, and that's actually some extra money. Secretary Selecki has been a huge champion on this issue, and Governor Gregoire. The tobacco prevention savings account had extra money in it to the tune of about $1.7. And so if we could ever get a budget passed, we would stop being the only state in the nation without a quitline for state dollars. So there has been money allocated for the quitline, 1.7, and we don't anticipate that going away in budget negotiations. So while this bill didn't get the quitline back up and running, we're hoping the underlying budget does.
Thanks, Erin.
Thank you, Lucy and Erin. We can take a little bit of time now if there's any questions that have come in on any of the policy bills. Thank you to all of our partners and presenters who have worked really hard on a very diverse set of bills that have to do with public health. So Betsy, any questions at this point?
There was one question about the cigar lounge bill, and how much money would the bill actually provide, or how much money does it require for both? Since you had said it was included in the budget, I think that's where that question is coming from.
Sure. Erin, do you remember the exact number? I think it's about $4 million.
Yeah,
But
it's $4 million a biennium. It's about 1.8 or so annually. But I think I heard a little bit in that question that we don't believe that to be true. We've had huge problems with the anticipated revenue from this bill. So I guess say $4 million every 2 years. That's lofty. That's why one of the many reasons we said we never want that money to be tied to anything we care about if this was to ever pass. Because I don't think it's going to bring in that much.
No, the assumption in that $4 million is that every single one of those 600 licenses would get sold in the first year, and that's pretty unlikely, I would imagine.
Betsy, any other questions?
We do not have any other questions at this point.
Okay, Betsy, do you want to talk through the next slide?
Sure. Just to let you all know, we do have some upcoming events and opportunities. April 17th will be our next webinar on leading in times of change. We have just sent out the call for abstracts for the 2012 Joint Conference on Health. The theme is Advancing Population Health with Results That Matter, and the deadline for abstract submission is May 25th. If you have any questions, please visit our website. There you will find the form for submitting abstracts as well as more information about the conference, including the objectives and the tracks. And then finally, this year we are having our first ever WSPHA membership drive, which will begin in April and last until the end of May. And so it will be a great time for you to renew your membership or become a member and encourage others to become members too. And you can join, find the membership application at wspha.org.
Thank you, Betsy, and thank you so much to all of our presenters. And we will perhaps either put together either an additional webinar or probably more likely an email out to the WSPHA membership when there is a final budget deal so that we can have some conclusion to the session and let everybody know what the final budget outcome is. Okay, thank you.